So welcome to our event on the implementation of patient-reported outcomes, and I will give the word to Meni Styliadou.
Thank you, Tanja. So welcome. So when we started talking about this event, we used to call it, and I still do, the round table. And there is a reason for that. So this is not a round table here. You've been placed in a theater setting, I understand. But the idea is really to help us think this through, because we're at a stage in the project where we really need a round table. We need a round table conversation about how to. And let me tell you why we need that. So when we started this project, from the beginning, the vision, the mission was to create a common language that we can use between clinicians and patients to give patients power, to allow patients to really communicating with the healthcare system on what matters to them. And we were saying from the beginning, standardized PROs, and we're very happy, or I was very happy with the statement. And what started happening in the context of the project is that PROs is something that was initially invented or started being used in clinical trials for a particular reason, to understand how a drug is going to impact individual patients and give patients the possibility to impact into the development of the drug. But what we were talking about here was something different. What we were talking about here was a conversation between physician and doctor in clinical practice. And that means a lot of things are different. It means that what we need to come up with is something that becomes a language that a lot of people want to speak, that it's simple, that it creates no burden, neither on the clinician nor on the patient, that it comes naturally, that can be really facilitated by technologies, but on a big scale and in a standardized way, but also importantly needs to have a certain level of scientific rigor, because if it doesn't, it's not going to be used by the clinicians and it is not going to mean anything to anybody. So how do you do that? And that is where we thought we're going to have this roundtable. Of course, we are starting by the PROs that are already there. That's very much the objective of the project, and that's what we are doing. Our teams, and Tanja will tell you more about it in a minute, have thought a lot about how to create pragmatic outcome sets that we can really implement in the clinical setting. But we find that this is a bigger problem. It's not just a problem about the project. It's how do you bring the PROs from the clinical trials to the clinical trial in a seamless way. You create evidence that can be compared. So you can compare the evidence from the clinical trials to the clinical practice in a way that makes sense, that has scientific rigor. And this happens in a way that doesn't create any burden for clinicians, patients, or the system all in all. So that's the objective of this roundtable. And I'm now leaving it to all you very insightful colleagues that have joined us here to give us the answers. But before that, Tanja will tell you a little bit more about how to set the scene. And then we have two fantastic panels. And I'm actually very, very grateful to all the panelists who took the pain to come and join us today to share the dilemma with you and hopefully together with you try to find the answers to this. Tanja?
So thanks, Meni, for the introduction. And like what you always say, Meni, we are partners in crime here in this project. My name is Tanja Stamm. I'm from the Medical University of Vienna. And I have a few housekeeping issues before we start really with the panel. So I was reminded to remind you that you need to sign in, please, for this event. And there is a list here at the entrance. Then we will have two panels now. So one will be on, will be more from the value, really the scientific perspective on patient-reported outcomes, and the other will be more on policy. We will have, or we have a lot of virtual attendance also, and please, so welcome all the virtual attendance as well. And you will be able to ask questions via Slido, and there will be a QR code which is displayed in the webinar. So that's also important if you want to ask questions, and we very much welcome questions. We will do the discussions in a panel format. So there will be opportunities for discussions. We will start with an initial presentation now, then we will have an initial round by all the panelists, and then we will open up the for discussions here, questions from the audience and also from the virtual attendants. And we will have a small break in between. Yes.
There will be pictures taken. So in case you don't want your picture to be taken, you need to note to say this. And the event is being recorded. And if you have any problem with that, again, you need to leave or tell us.
So that's the advantage or disadvantage of all these technologies. So like Meni said, the idea was to dive a bit into the implementation of patient-reported outcomes. And I would like just to draw your attention a bit why we need patient-reported outcomes in real-world settings. And there have been a lot of discussions, or what Meni has also raised. PROs have been developed mainly for clinical trials, to be like endpoints there. But why is this all needed in real-world settings? And that's one of the slides we use actually very often in the H2O presentations. And why are PROs important in real-world data? First of all, I think it's important for the patients, and we have a lot of patient representatives here in the room and also in the online attendance. So in the H2O project, we very much work with patients and have patients involved in all of our decision bodies and all of the work we are really doing. Yeah. So the idea is with H2O, we want to improve this dialogue between patients and clinicians, so in order to really improve clinical practice to produce better outcomes in healthcare. So it's a very practical thing. Yeah? We want to inform the healthcare providers, of course, and there's a lot of interest also from our side, for example, as the General Hospital in Vienna or the Medical University, but also other large university hospitals in Europe are very interested to have data, to have outcomes data, to run dashboards, to really use this also for improving the quality of the service. And we want to help the researchers in the future, researchers from all kinds of institutions, in order to have larger, integrated, standardized outcome sets for really running this large analysis and making use of the big data we generate in healthcare. And we want to improve the sustainability, and sustainability is probably one of the key challenges in the future in our healthcare systems everywhere, maybe in the world, but specifically also in the Western world. It will be more expensive in the future, and we really need to think of strategies how this can be sustainable. And if you look into what is really there in terms of evidence, so whereas the hard evidence, we even have studies that measuring PROs improves the health outcomes, especially in oncology. It was actually shown by Bash and team that it improved survival. Yeah, so we need this kind of studies, of course. We have discussed before in a steering committee meeting of the H2O project that generating evidence, creating a machine that generates really evidence for patient-reported outcomes in real-world settings will be one of the future tasks. This also goes in line what we will do for the European Health Data Space, and there the request is to have some primary use context of the data. So that's where we really need the PROs in clinical practice to improve patient care. And on the other hand, we also have the secondary use. So we want to make this data accessible and usable in the healthcare systems. And that will be really important also to prove the impact of this in the future. So I've chosen another example, and I worked for a long time in rheumatology and I think this is a very interesting finding, what we also had in a study where we participated recently, and it actually showed that the patient global assessment, and that's an assessment that the patient does, so it's a patient-reported assessment with can be a 10 item Likert scale, or it can be a line in a visual analog scale where the patient marks the line how well he or she is doing in terms of the disease activity or in terms of general quality of life. And this was actually a factor that showed, or a key factor, why people did not achieve remission in rheumatology. Yeah, so the other clinical variables were sometimes very good, yeah, and people achieved remission biologically, physiologically, but the patient-reported score was not in remission. Yeah, and I think what that really shows, and in rheumatology, we have a concept which is called treat to target, and the idea is to treat patients not like just asking how are you doing and then you get some kind of drug, like this was done maybe 20 years ago, but really measuring an outcome and treating the patient so they would achieve remission or low disease activity, at least in an appropriate time frame. Yeah. But what it really shows is that there is a different concept how patients see remissions, how patients feel about themselves being in remission, and about the biological variables that we measure and what is remission in the eyes of a rheumatologist. Yeah? And I think this shows very well why we need these patient-reported outcomes, because it's not enough to measure the clinical biomedical data. Yeah? If you measure that, you would consider a patient to be in remission, but the patient is not. Yeah? And that, I think, shows very well why we need these PROs really also in real-world context, not only in the clinical trials to show if a drug performs well or not, but we need to focus really on the needs of the patient. And that's what we don't do that much right now. So that was actually one of the aims in the H2O project. So what is really the H2O model? The idea is to have an emphasis to improve the patient and health professional communication, using these patient-reported outcomes to make the needs of the patients more visible, so that we don't make the same mistake what I just showed, that we only measure the lab values, for example, or some biomedical things, but we really consider also the perspective of the patient. And that should improve the conversation, the consultation with the health professional. For that, we have created standardized pragmatic outcome sets. So in order not to have a large burden on the patient that they need to fill in hundreds of questions, but to keep this to a real necessary minimum in a way, we are giving patients technologies to measure these outcomes. And in the end, we will want to make this data available under a governance model, a multi-stakeholder governance model, where also patients will have a saying in, and where data should be also accessible, for example, to patient organizations. So to really all types of different stakeholders, aggregated or also patient-level data, depending on research questions and what the stakeholders need. So the idea is really to give power to the patient. Patients will have technologies where they can track, record the outcomes. We will have visualizations, yeah, which are which can, on the one hand, inform the patient, but which can also be integrated in a dashboard for clinicians or for a wider audience. Yeah? And we have created national entities in 4 countries, and you see them here in dark blue, and that's actually Spain, the Netherlands, Germany, and Austria. And we have some more countries here which are marked in light blue, and Denmark is one of them. And we hope to set up another legal entity, another observatory, an outcome observatory also in Denmark. We have created a model to assess the progress in each of these countries, and we will have maybe something on the technology. Yeah, that's why we have put this here, the certification H2O implementation tested, because H2O really focuses on the implementation of these PROs, and some of the PROs might not be fit for implementation. Yeah, and that's why we have put that here, because that could be one of the future tasks. So with this, I would like to thank you very much for your attention, and I would like to ask my panel my fellow panel members here to join me on the stage. And that is Valentina Strammiello. Valentina is the Director of Programs at the European Patient Forum. Then Professor Matthias Rose, who is the Medical Director of the Medical Department at Charité Berlin. Professor Linetta Koppert, she is online, I think. Do I need to do anything, or can you display Linetta on the screen here maybe? Or is it not possible? So maybe then we should go on, because this is like a little bit of a weird slide anyway. Then Dr. Simone Lubowitsky from the Medical University of Vienna. She's a research associate working in hematology. And Professor Annette de Turin. And Annette is Professor of Rheumatology at the Institute of Clinical Medicine at Aarhus University Hospital. And Annette and I, we know each other already a long time from the European Society of Rheumatology. And it's nice to meet outside rheumatology again. And now we can see Linetta here directly from the operation theater. So Professor Linetta Koppert is a specialist for breast cancer oncology and one of our partners in the H2O project.
Hi.
So I thought we have a lot of people on the panel, and maybe we can just make a first round where every one of you could have some initial statement maybe on the topic we are discussing here. And maybe we should just start in the order that you are listed in the program, and we start with you, Valentina, first.
No pressure. So I see a big potential in H2O. And as we started this project, I immediately thought this could be life-changing for many patients. Because, of course, we acknowledge that there are more or less threatening conditions, diseases. But all of them come with a burden for the patient, and we need this to be captured in a systematic and standardized manner. And I think with H2O, we can reach this goal, at least bring to the patient community a tool that they can use together with their healthcare professionals and better communicate with them to have their concerns better addressed and better communicated, because often patients don't know exactly how they can communicate with healthcare professionals. So there is also potential of empowering the patients and improving their health literacy, hopefully. I see the benefits are multiple, so we can keep talking for a while. But in a nutshell, I think there is a big opportunity here.
And where do you see, Valentina, really these patient-reported outcomes in real-world settings, also beyond H2O? Do you think it's very important to use that, or would the patient think that it creates a lot of burden for them?
It should be, this approach should be exported to other disease areas, of course. In H2O, we are simply piloting what I'd like to see in other disease areas as well. In principle, what I think is really what matters to patients is to have a good quality of life. Of course, the health status is important because no one wants to see their health condition deteriorating. But at the same time, we need the quality of life to be captured, which comes with potentially no side effects coming from the treatments. We hear often of mental health aspects that come together with the health condition. So it's quite key to make sure that the needs of the patients are really met. And I always fear that there are quite a lot of unmet needs still to be addressed, despite the fact maybe treatments are available. And that's where I would like innovation to be targeted, to really reduce as much as possible those unmet needs.
Yes, thank you. I think that's very important, to consider also the perspective of patients. Matthias, from your perspective as a clinician, how do you see the use of PROs in real-world settings?
Yeah, thanks. Maybe there are two levels I would like to answer. So the first thing is more like the most immediate level, like being a physician, being an internal medicine doctor. So why, what we do as doctors or physicians is, well, we ask the patients for probably the last 1,000 years, how are you? and which is not unusual. And what we do with PROs is put this "how are you" in a number. So that's not really rocket science. So, but why we should do that? Because if I just do this on a regular basis, and of course I do know my patients how they feel, but to transfer this knowledge, how they feel, which is obviously important, we ask them because we are interested how they are, and then they start talking about, I have pain in my stomach, or I'm depressed, or whatever it is, and then we act on this. So, and the question is more why we haven't transferred this knowledge, and Meni was talking about this, which is out there of PROs for 30 years, why we haven't used this scientifically, means empirically, means put in a number. So I think we just leave some kind of a level of data, so to say, a monitor system, which is the patient. The patient is monitoring himself. So we invest in, a lot of money in digital devices like, I don't know to mention any brand names, but we monitor our health, but we do monitor our health anyhow every day at home. That's the reason we can answer the questions. How are you? So the question was the crisis in, I think, all over the world, but also in the development countries, in the hospital system, that we don't use this monitoring of the patients, by asking them how are they, and then transfer this in a digital age that we can ask them not at the, hospital, but we can also ask them at home. And you referred to the BASH study, which is more or less monitoring how are they, outside the hospital. So this is already so obvious that we should do that. So just put this, how are you, in a number, and then go outside the hospital. This is, and I can tick all the boxes like, it's intersectoral approach, monitoring system. That's cool in itself, but that wouldn't address anything what Valentina just said. We would just improve medicine, which is good. But I think the thing which is even more intriguing for me, or which is more, I think maybe even more interesting, is the change of medicine in itself. And this change of perspective, I think, is very much due to also that we react to a success for the last 100 years, is that we, it's not that when medicine started, we had a kind of holistic view on the patient, because there was no way to focus on cells or to focus on organs. But over the last 200 years, we have been very successful to focus on diseases, and treat the diseases, because if you cannot define a disease, you cannot treat the disease. So, and we have an increase of mortality about doubling when you compare this in the 1980, 1800. We were living 40 years, now we are living 80 years. So this is a success story to focus on organs, to focus on disease, not on patients. But now the change, I think, in medicine is that we have chronic diseases which we cannot cure, except of cancer. I think most of the diseases we are dealing with, even in university hospitals, are the task is to make the patient feel better. And if we don't assess this, we cannot answer this question. So, but this is a fundamental shift in perspective. So it's really patient-centered care, and that wouldn't need to have any justification like the BASH study, because, well, we justify ourselves because we are successful what we are supposed to do, and we wouldn't need those kind of arguments which are just put in the first place, like we have a better monitoring system. So I think two very easy reasons to start with. One is to make things better, very easy, cheap. And the other thing is that we should do and justify ourselves what we are paid for.
Yes, thanks. I think that's very important. And also the point you made about patient-centered care, because that could be a reason in itself, why we need really to assess the perspective of patients. So maybe, can we ask you, Linetta, maybe next, what is your perspective on using PROs in real world settings? And I know that you have always or very often have come together also with a patient and have discussed really this communication, or how this can really be implementable, and how this can be of benefit for patient and for clinician.
Yes, thank you. Can you hear me?
Yes.
Yes, okay, great. Hi, everybody. Well, I think I really want to add to Matthias and Valentina here on the fundamental change of perspective. To be honest, the use of prompts in the outpatient clinic really made me another doctor. And that's really what it is. So the conversation about, how are you then in a number? I think that's what's really happening now. And we're talking about outcomes that really matter to patients. So consider a consultation room where I'm with my patient and she filled in her prompts and we together decide on how the conversation should go and what it should be about. And therefore, we have a conversation that's different when you have a 10 minutes question, how are you? And 10 minutes is the time you have to see your patient. Now working with prompts for many years already now, since 2015, these outcomes to be discussed should be really meaningful. That's so important. And I think the rest of the discussion will also be on this item, but also clinically actionable. So now there comes an era where we together as healthcare professionals should strive for having standard outcome sets to be meaningful and clinically actionable. And that's where we should meet with patients and ask them how we should proceed with it. It's my really dream that when we have within H2O this really good pan-European observatory, that there comes a moment that in the outpatient clinic we also can use the lessons we learned from collecting prompts to predict outcomes for patients in another way than we used to do. Normally, I make drawings of how I can operate on a breast of a woman when she has cancer. But now we also can have, in I hope the near future, a way to predict her outcome also concerning quality of life. And that's the thing I really dream of. So I'm really passionate about using prompts. I think it's really essential. And the future there is bright. And I'm looking forward to it together with all the H2O partners.
Yeah, thanks, Linetta. I think important is really also that we measure something which matters to the patients. Yeah, and that's why we have involved also patients in all of our boards and all the committees and the discussions we had about the core outcome sets. Yeah. So that's a really important point. Then maybe we could ask you next, Simone, from your perspective, and you work in a different area, which is hematology, but it's probably very much related to also what we have, what our aim here is and what we have achieved. And maybe you can tell a little bit about your project and what you have set up. And we have also discussed about some collaboration with H2O, and maybe you can give us some insights here.
So some insights. We did a randomized control trial during the years 2014 till 19, and we got involved with 12 clinics at 5 European countries. We collected data from patients of 830 patients in a whole and 140 patients at the Medical University in Vienna. And yeah, a lot of cancer. So we worked with cancer patients, and the cancer patients always ask us, what can we do? Can I help support getting healthy again? And then we say, okay, let's make some diary of your symptoms. And by collecting data on a daily basis, we have the set of data also at our place, and sorry, lost it. So we have
what is your so it's different PROs also that you ask the patient, so they fill in how they are doing in their daily life, and you visualize these outcomes, and patients see this then, or they use an app, right? So they install this on their phones, and then they...
Yes, thanks. The patients answer on a daily basis on their own smartphone their symptoms during the last 24 hours. And these are 13 questions, and they are just about the side effects during chemotherapy treatment. And on the other side, we also collect PROs on a 3 months basis.
so we can see how is the patient doing, not just medical wise, also on what is the quality of life? Is he anxious? And we also have to consider that patients are in the clinic, and therefore their next control appointment or something, and getting chemotherapy in the next 2 hours, and they are anxious. And so when they can answer the pros at home in their comfortable zone, so you get real data of how they feel.
Yeah, that's maybe also very important, the context where this is collected. And I mean, there is also a different system which actually do not only collect the PRO, but also collect the context. So whether if you are in a stressful situation, you will answer this differently than if you are in a relaxed situation, maybe. Huh? Yes, thank you. And then Annette, you are kind of the local here in Denmark, not here in Copenhagen, but in Denmark.
Yeah.
And so what is your perspective on PROs in real world settings? What is your, I know you're running also a very big project in this area.
Yes. Yes. First of all, I would like to say that I come from Central Denmark region, where we have in 2011, we launched this system called Ambuflex, which is a system that can systematically collect PROs and which is integrated into the medical journal. And today in Central Denmark region, we actually have 62 different PRO solutions running actively in Central Denmark region among approximately 40,000 patients. So in our region, and I think in Denmark in generally, it is a big thing, this thing about PROs. And I completely agree with what has been said, that it should be fit for purpose. It should be designed in collaboration with relevant stakeholders so that it is relevant for both the patients in center, but also the clinicians, because they are also users. And if we forget the clinicians in this process about implementation of patient-reported outcomes, they will not use it. And furthermore, I think it's also important not only to say that we create big data that we can use and aggregate. We also need research, health services research about how do the different solutions work, and do they actually fit the purpose that they were designed for? Because it's not always easy to find out in advance. And sometimes you actually get a little bit surprised. You get another answer than you expected. So I think it's also important in this transformation of the healthcare system, which I think this is greatly a part of course, that we use the voice of the patients, but also that we use it wisely to say what works and what does not work. So that we do not only implement more and more PRO solutions without taking into consideration if it actually works for the patients that it is intended to work for.
Yeah, that's very important, I think. And we are also running a feasibility study now in H2O in order to find out exactly what you said. Do you think that we need different PROs in clinical trials and clinical practice?
We have discussed that earlier. I think I'm very much in favor for saying that what we could agree upon should maybe be domains, that we sort of say we would like to have PROs within these domains, say health, quality of life, pain, whatever relevant. But and that we need to use validated PROs, but it's not necessary that we use exactly the same. Because, for example, if we would like to do a systematic review or meta-analysis, we can statistically come around that it's not exactly the same. We can come around that. And I think we will be too tied up if we should all go in the same direction, exactly the same direction. But that's my opinion.
What is your perspective on that, Valentina, from a patient experience, patient side? Do you think PROs need to be different in trials and in real-world settings? Should we, because what we also discussed is to have some continuity would be good, yeah, over the, also not only over the course of the patient during the life, but also over the life of a drug maybe, yeah?
I do agree with Linetta that there might be some common measures for sure, and I don't see why we couldn't find a way to somehow coordinate. And I do understand also that maybe the purpose of PROs in clinical trials is somehow different from what is expected in clinical practice. So they need to respond to different needs. I personally don't find it, I don't think it's a big problem, as the purpose is always to capture what is the perspective of the patient, in this case, what is the experience of the patient while living with the condition, having access to a specific treatment. So I feel it's still there is an opportunity to find some alignment, but in any case, even should the alignment not be there, it's not the biggest problem. I feel. I think we need some openness and have indeed the ability to also draw some conclusions from those results. I would also add, what is important is not only to capture this information through PROs, but also have healthcare systems to build on this information and take some action.
Yeah, that's good. And what Annette said, Matthias, the domain standardization versus the instruments, what is your perspective on that? Is that the way to go in the future?
Oh, well, probably you'll be very surprised by my answer. Yeah, of course. I think it's a natural way to do it, because when we think of and we touched this a little bit, you know, the instruments, you know, has been started 30 years ago for a specific purpose, you know, and you're building a race car maybe, and you wouldn't assume that you have a race car which is very useful in daily traffic. So it's still a car, but it doesn't have the same features. But you know, I think with the domain-oriented you know, idea you mentioned, we would be much closer to any kind of assessment which we are very used to in biomedical in medicine. So when, you know, when I check, you know, if my daughter has fever, probably sometimes it's enough to just feel if she has fever. But you know, if I'm intensive care unit, you would love to have a precise number, but it's still the same scale, the same temperature. And it's good that being here in Denmark, you know, it's almost 100 years ago exactly, when Rasch was one of the major, you know, psychometricians, and I think we are all living on his ideas. He provided a metric that we can, you know, liberate the instruments from the scales. So we once, and this is one of the H2O, I think, big achievements. If we agree on the scales, we don't have to agree on the instrument. I think this step is needed to say, well, this is Celsius or Fahrenheit, whatever it is, but we don't agree on the thermometer. And that, I think, gives the flexibility to measure physical function or pain in clinical practice maybe more precise, or maybe with shorter instruments, but still being comparable to clinical trials where physical function can be measured with a, you know, heavily funded study nurse or with a sponsor, and fulfill the needs for the FDA, for the regulators. And I think, just to add me one thought of this, there's also a challenge to educate the regulators, because we all want to look at real world data evidence. Nobody needs to be, you know, convinced about that. and we also are interested in the outcome for the patients. So everybody says yes. But then when it comes to the methods, obviously what we agreed on also is, well, it needs to be usable, it needs to be applicable, and not additionally paid. We have to, the regulators also have to understand that some of the tools, they are still validated and rigorous, but they will be different. They will be domain oriented, and not as the tools they are used to work with for many decades.
Yeah, thanks, Matthias. Thanks for mentioning the Rush model. It's always great to hear that. And you already came up with the topic I wanted to ask Linetta now. So Linetta, from the regulatory perspective, what do you think? So I know you have also in the Netherlands this very large or you have organizations who collect this big data in healthcare, regulatory organizations, and you have a lot of work also to do with them. So what do you think, what authorities, what regulators would they look into continuity over clinical trials and real world data in terms of PROs? And how do you think regulators would accept PROs more in the future, maybe?
Yeah, thank you, Tanja. A difficult question, and we should ask the regulators themselves, and you will, I think, the next panel. I think that we all stakeholders agree on this kind of, I call it the modular approach, so that we are domain oriented, and that that in the end, the things we want to learn from the data can be taken out when we have this kind of core domain approach. In discussions we have, I'm really jealous on Annette from Denmark, hearing that it's already so common to use it, and I think that's not where we are yet. And maybe in my institution, but nationally, no. I'm the director of the breast cancer registry in the Netherlands, and the PROs we want them in the registry, but it's only a really small part of patients who have these outcomes in the registries. So we're not there yet. And I think that the answer maybe came a bit from the field, that institutions that implemented the more large outcomes such as ICHOM develops, for example, for breast cancer, that in the end, the healthcare professionals really direct into a kind of mini PROM system and say, well, let's do 14 questions at max, and that's it. And there we struggle, since maybe the value of the initiative is so much less when we make it such a small initiative. So we're a bit struggling there, to be honest, how to do this. And I really believe in that maybe it's good to kind of have a basic set and add-ons there. Add-ons for maybe research, add-ons for patients that really like to answer that kind of questions, and in that way have a kind of broad and real world experience with the PRO. So not only for the happy few who are early adapting and happy with it. So discussions with stakeholders, as you asked me, they are really happy to have PRO data. But having there more broadly is really important. Let's start there. That would be my answer, I think.
Yeah, thanks, Linetta. And we will ask the regulators, I think, in the next panel. And so you have all to stay, also the online audience, and listen to what they will say to this. So maybe another question to you, Simone, in terms of adherence, in a way. Adherence is maybe not an ideal term, of the patients with the PROs. So how is that in your trials? Do the people stop using this because it's too burdensome, or do you have really lots of people who will stay with this and say this is exactly what we need?
So we didn't lose a lot of patients. They loved it. And I think it's because of the contact. So the patients filled out their daily question set, and we were in contact. When there were symptoms and we contacted the patients, they felt safe, and they were less anxious. And I think because of the contact, they felt treated in all kinds of ways. And I think this is key for successful healthcare.
Yeah, I think so too. Yeah, and it's good to hear because that's an important finding, I think.
We
yeah,
also
that-
had one lady, which was she was 85 and hadn't any experience with smartphones or something like that. And I said to her, okay, let's try it. We make it together. And if you don't like it, you return the device and you don't have to participate in the study. And we tried it, and she loved it. She had it for half a year, the device, and she felt safe. She felt in contact with us. And yeah, I think this is a big adherence point.
Yeah, thanks, Simona. And maybe one last question before we open up to the audience, to you, Annette. We are all a bit jealous about the big numbers and all the people filling in the PROs in Denmark. So how do you see the future of H2O in Denmark? Should we, I mean, we have concrete plans to set up something here too. And also the European Observatory will be located in Denmark. So maybe that's the ideal place to be, right?
Yeah, maybe. Maybe it is. We do have a lot of experience after all, so we are happy to contribute if we can.
Yeah, we will all learn from
Yeah.
you. So let's ask the audience maybe for questions. So this applies to the people here in the room as well as to the people in the online.
Yes,
And I look to Ren because I think you are the one who can.
yes, already.
Okay, there is already a question. In all your experiences, what are key factors to successfully implement PROs? Who wants to answer this from the panel? I think you all could answer this. No one.
I think one point is keep it short, because we had in our study 8 questionnaires and it took approximately 1 hour to answer all the questions on a 3-month basis, and this was quite a lot. And I think keep it short is a factor.
So no 1 hour questionnaires for people, right?
I also think the need must be there for the PRO solution, so that also the clinicians can see the use of it, because otherwise they are not going to use it. And I think that the patients will not answer the questionnaires if they are not addressed by the clinicians during the consultations, because they answer these 8 1 hour, I don't know how many questions, and nobody raises any of the issues that they have been sitting, ticking. And then, of course, you stop doing it if it's not used. I mean, that's natural.
Yeah, I think I can only add to this something what Linetta just said. You know, from the clinician perspective, it needs to be actionable, that you solve a problem which you have, so you can, you know, discharge the patient a little bit earlier because you can monitor them.
Yep.
And that is our surgery department or the orthopedic surgeon, they're interested in when people can start working. But I also would like to add some things. So that's something you solve a problem. And the other one is that obviously people are interested in, so it needs to be driven also by the senior, the senior management. I think that they really like to support this for at least a complete rollout. And we decided the Charité to have everybody with PROs now during the next years being covered. That certainly cannot be done by individual champions. But maybe just one thought, I wouldn't have thought that I would need a smartphone before I got one. So, and there's also a learning curve, you know, once you see some information you never thought of, you start using them. So it's a little bit of also an education is that I think we should be very sure that the reports are nice and the integration in the KISS or electronic health record is, feasible, not 5 clicks to 1 click. So like we see the laboratory results. So it's a lab value. First, it's a lab value. And we are used to see lab values which needs to be fit into EHR. But then I think we will see more use.
And I think like that is taken up in practice was one of the key issues when we looked into the evidence how to implement PROs. Yeah, so that it's really important that it's addressed in the clinic. Yeah, and it's not.
And maybe interpretation also. So
yeah, and some kind of interpretation. And I think what is also needed, and that's why we also focus on technology in H2O, is some kind of visualization or something where you do not have to go through every of these questions in the end. Yeah, because then the 10 minutes that Linetta mentioned will never be sufficient. Yeah. Any questions from the live audience here? Aha, Linetta.
I'd like to add a point that was not mentioned so
Yes.
far. An enabler could also be the co-design of the questionnaires together with patient advocates, because what we have heard in the past is that sometimes patients feel they are not asked the right questions, the ones they would like to respond to. And so maybe it would be good to bring a patient advocate on board at the very beginning of the process to co-design them, make sure that they are lay language and indeed accessible, make sure that the tools are user-friendly.
Yes, that's a very important point. And I think there's a lot of experience also with working with patient research partners in these kind of projects, and a very long tradition in many areas also, and very important to mention. Linetta, did you raise your hand? So we will give you the last word maybe here now, because I think we need to finish a bit earlier because we have to have a short break before the next panel starts. Yeah.
Well, maybe the keywords, I think the co-creation with patients, and then also the technology. So it should be as a comprehensive dashboard in your electronic patient record. That's really, that's needed. Otherwise, you're not facilitated as healthcare provider to, in the end, have the conversation on the pros. And the education. And don't forget the nurses. I think nurses and specialized nurses are the ones who are driving this initiative all the time. So we need to educate them and train them. And that's something that should be, I think, more highlighted in the world. Yeah.
Yes, that's also very important. I think dashboards to visualize this and to make it really usable in practice, and also the other health professionals like nurses, I think they are very important when implementing this. Yeah. So I think with this, we would round up our panel here, and we will have a short break. The next session will start at 5, and I think you can, maybe there's some refreshments outside. We need some microphones exchanging here, and we hope to see you all back after the break. Thank you very much for attending.